Welcome back to MLT 120. Today we're going to be talking about some common tests used for coagulation studies. And remember, we use the blue top tube for testing in coag, and the anticoagulant for the blue top is the sodium citrate. Also on this first slide is a picture of the Stago machine. This is one of your automated coag analyzers. Just some introductory information on coag test. Why do we perform coag test? We're trying to see if patients are able to form clots normally and to monitor patients on anticoagulation therapies. Some of the drugs that we're monitoring or the blood thinners we monitor is heparin, Coumadin, and Coumadin, the generic, is warfarin. So you may hear some of those drug names commonly when we're talking about patients on blood thinners or anticoagulant therapies. We also do coag testing to look for conditions that will cause increased risk of thrombosis or clot formation, and those might be those patients that have protein C or protein S deficiencies that we learned about in the coagulation lecture, or even the factor V genetic mutation. Two common coagulation tests, or the two most commonly performed coagulation tests in the lab, is the PT-INR and the APTT, or just simply called the PTT. If we're able to reduce the risk of clots for patients, we reduce the risk of things like stroke, heart attack, and other serious medical conditions. As far as specimen collection for coagulation tests, we've talked about this in the past in previous lectures, but for our specimens, we want a blue top tube with the sodium citrate as an anticoagulant. Blood samples must be drawn into the tube with a minimum amount of trauma. If there's a lot of trauma caused during collection, you could initiate the coag cascade, and that would cause the specimen to be invalid for coag test. If there's hemolysis or hemolyzed plasma in the specimen for your coag test, it can negatively affect the accuracy of results for the specimen. Another thing to consider in your anticoagulant tubes is the anticoagulant to specimen ratio. There needs to be 1 part sodium citrate, which is your anticoagulant, to 9 parts blood. If this is not the case, then the specimen is going to have to be recollected. And you can see over here, this is an example of different degrees of hemolysis. This is what you want. You want nice clear plasma, and this would be hemolysis. But this is showing the anticoagulant to blood ratio. This is showing a tube that's insignificant as far as the volume in the tube. There's all kinds of bubbles here, so there's not enough volume of blood in the tube. You have to fill it up to this line here to get the 1:9 ratio. Sometimes another thing that you have to consider, if you're using a butterfly, there's air in that line, that tube that connects the butterfly needle to the tube. So sometimes you have to draw a waste tube in front of the actual tube you're wanting to draw your specimen in, because if you just automatically put your specimen tube on, there's going to be a it's going to allow air to draw into the tube, and you're never going to be able to fill your tube up to that 1:9 ratio. As far as processing the coagulation specimens after collection, the tubes are going to get spun down in the centrifuge to separate the cells. The red cells are going to be on the bottom, and the plasma is going to be on the top. And you can see that on the image here. The plasma is on the top and the red cells are on the bottom in the sodium citrate tube. The specimen must be centrifuged at a speed and at a time that produces platelet poor plasma, or PPP, platelet poor plasma. Platelets should not be floating in the plasma because platelets secrete factors that can interfere with a urocoag test. Specimens in certain coag tests must also meet certain criteria for age and temperature of the specimen. For a lot of the coag tests, the specimen cannot be more than 8 hours old. Some tests, they can't be more than 4 hours old. So you have to be very aware of that and be clear on certain testing criteria on a particular test. If the blood is too old, of course, you have to have a redraw. Some tests have to meet specific temperature requirements. Maybe the specimen has to be stored at room temperature only before testing. It cannot be refrigerated. So again, you have to be aware of what certain criteria or certain testing criteria that a test requires for coagulation. Because your coagulation test has to meet certain requirements and we have to be real picky on our specimen, these are some reasons that we often reject coag test specimens. Of course, if your plasma is hemolyzed, we'd have to reject the specimen. If there's a clot in the specimen, it would have to be rejected. If the specimen has too much in it, or overdrawn, or if the specimen is too little or too short in the tube. And this is example of overdrawn. Here is the line. Here's the collection line to get your 1:9 ratio. Here's the line over here. The ones on the left hand side, the plasma is going all the way up here. So these are all overdrawn, so they would have to be collected because they're too full. The ratio would not be correct. The plasma's way down here. These are obviously too short. Again, the ratio would not be correct for anticoagulant and sample. Improper time between collection and test performed. Again, like I just said, some of the tests are very time sensitive from the time of collection to the time of testing. Some have a window of 8 to 4 hours. So if it's been over that time period, then you have to recollect and get a new sample. Improper storage tempers, we just mentioned also. Some coag tests have to be stored at room temperature. They cannot be refrigerated. If a coagulation sample has to be rejected, basically we just need a redraw on those coagulation tubes. One of the most common coag tests that are run in the laboratory is the PT-INR. PT stands for the prothrombin time, and this evaluates the ability for blood to clot. The INR stands for the International Normalized Ratio, and this number helps ensure that the results from lab to lab are the same. And both of these numbers are reported together to get the PT-INR. For the PT-INR, of course, our specimen is our sodium citrate, and we're going to be using the plasma. We want plasma that's not hemolyzed. You can have a specimen that's up to 24 hours old, and we want our specimens at room temperature. And the stopper must remain on the tube, so we don't want any caps that have been removed off specimens for our PT-INR specimens. The tests are performed on an automated analyzer. So this is what one of the automated analyzers looks like. This is the Stago, what it looks like on the inside, and you can load your specimens up here in this rack. All the reagents are loaded up on this rack, and there's an arm with a probe that can come and sample reagents and the samples, and it can move along a track system and do what it needs to do. The reagents for this test is thromboplastin. Remember, thromboplastin helps kick off the coag cascade. And also the reagent is calcium. And these guys are usually manufactured as one reagent together. And if throughout the process, the instrument's going to incubate the plasma and the reagent at 37 degrees Celsius. The instrument will add the thromboplastin and the calcium reagent to the patient's plasma, and a timer will start to see how many seconds it takes for that patient plasma to form a clot. When the instrument detects a clot, it's going to record the number of seconds it took for that specimen to clot. So the normal patient, or the normal PT-INR, is between 10 and 13 seconds. So that's your normal range. If it takes longer than that for a patient to clot, that patient is considered to have a bleeding problem. So how does these automatic coag analyzers detect clots? What's the mechanism or the method to detect clots? There's basically two methods. There's the photo-optical and there's the mechanical. For the photo-optical, basically a light is shown through a cuvette, a test cuvette with the sample in it. And when the fibrin clot forms, the way the light shines through the plasma, because there's a consistency change of the plasma, it's going to shine through differently, and that's going to trigger the machine that, hey, there is a clot being formed. And that's what's being shown up here in this top image. This is the photo-optical image. Here's your little test cuvette. Here is your sample of patient plasma. Clots have formed, so the light no longer shines through like it originally did before clots were formed. The consistency has changed. The mechanical method is down here. This means that there's some kind of physical method, such as a probe, here's the probes, or metal balls used in the patient plasma to detect a change in consistency of the sample. And that's when it tells the machine or the analyzer, hey, there's a clot been formed. So this is like when you have a mixer and you have the beaters in the mixer, and the batter's getting thicker and the beaters can no longer rotate as well as they used to. That's the same way this is. When the clots form in the patient's plasma, the probes or the metal balls can no longer rotate like they could. So that lets the machine know, or the analyzer know, hey, there's clots that have formed in the sample. So like with most of our automatic analyzers, there's certain situations that can cause interferences or problems with the analyzers. In the photo-optical method that is used, there's two main interferences with our samples. There's if we have enteric plasma, which is our amber yellow plasma, and that's usually due to liver problems, or our lipemic plasma, which is usually a milky looking plasma due to increased lipids. So these colors and more thick plasmas cause problems with that light being able to shine through our specimen, and it gives us inaccurate results. Because both of these interferences have a problem with the light detection, being able to detect a clot, we usually are going to use more of a mechanical probe or mechanical method to detect a clot. If we don't have that other option in our laboratory, sometimes the sample is sent out to a reference lab for the reference lab to run the coag test for us. The PT-INR measures extrinsic pathway factors. If a patient has a deficiency of any extrinsic pathway factor, the result will be prolonged clotting time. PT-INR is used mostly to monitor patients taking Oral Coumadin, or remember the generic of Coumadin is warfarin. Coumadin affects factor 7. Doctors use the INR part to help decide the Coumadin dosage for a patient. If you look at the scenario in the last bullet, if you have a patient that has a factor 7 deficiency, the patient's PT test, will it be normal? Probably will not have a normal PT. It will be prolonged because the factor 7 is very important in the extrinsic coag cascade pathway. So let's explain exactly where we get that INR result a little bit better. INR is the International Normalized Ratio, and this is a calculated number used in a standardized PT result. Years and years ago, for the thromboplastin, it used to be manufactured out of rabbit brains, and it was very difficult to get a lot the same from lot to lot. So who stepped in? The World Health Organization, and they required thromboplastin manufacturers to provide a sensitivity index number, or a ISI, or International Sensitivity Index, with each lot that was manufactured. So all labs must establish a parameter called an INR, or the International Normalized Ratio. And to do this, they have to use a formula, and it's calculated using the International Sensitivity Index, the normal patient mean, and then the patient's PT results. So this is the formula down here that's used to calculate the INR. Now, you do not have to memorize this formula or know this formula by heart. I just wanted to show you this formula so you know where we come up with this INR. On our automated analyzers, this formula is plugged in and it usually calculates it for you. So you don't have to calculate this by hand normally. The INR results, again, it's used to help standardize results for patients on Coumadin therapy. Another very common test done in coag is the APTT, and that stands for activated partial thromboplastin time. It's also known more short as the PTT, and this measures how long it takes your body to form a clot. And again, the specimen is still your light blue top tube, the sodium citrate tube. And this is the test that you have to run within 4 hours. Your reagents are calcium chloride and actin. And in your automated analyzer, reagents are going to be added to the patient plasma, and they're going to be incubated at 37 degrees Celsius, just like in the PTINR. Normal patients clot in 26 to 37 seconds. So that's your normal range for your APTT. And something to remember with this test, this measures your intrinsic pathway for your coag factors. Measures the intrinsic pathway. It's also used to monitor patients on your heparin therapies. Another thing we have to be worried about in coag is platelets, or our platelet count. We learned in the previous lecture about secondary and primary hemostasis. Secondary hemostasis involves our coagulation factors, but primary hemostasis involves our platelets. We must have enough, or enough quantity of platelets to maintain hemostasis, or stop the flow of blood. And they must be able to function, those platelets must be able to function properly to maintain hemostasis. And if you look over here, part of that primary hemostasis is being able to form that platelet plug. And we use a test in coag sometimes to test platelet function and to see if we have adequate numbers, and that test is called the bleeding time test. Here is the procedure for the bleeding time test. We'll look at some images on the next slide for the bleeding time test, how it's performed, but let's go through the steps first. This is, first off, a very simple test. You put a blood pressure cuff on a patient's arm and you pump it up to 40 millimeters of mercury, and this is just for standardization. The patient's underside of their forearm is disinfected because this is where you're going to perform the test, and the device, or a device, is used to make a small cut in an area on the forearm that is free of veins. Once the cut is made, a timer is cut on simultaneously to determine the number of seconds it takes for a patient to stop bleeding. While the timer's going, every 30 seconds, a piece of filter paper is used to blot the blood spot from oozing from the small cut. When blotting, you want to make sure to blot to the side of the cut because you do not want to disrupt the platelet plug from forming in the incision. So let's look here at how they're performing the bleeding time test. Again, the blood pressure cuff is put on the patient's arm up here, and it's pumped up to 40 millimeters of mercury. They take a lancet and prick the forearm of the patient, and then they have their blotting paper ready. As soon as the lancet pricks the arm, you start your timer. And every 30 seconds, you take your filter paper and you blot the blood spot. So you can see this was the first 30 seconds, second 30 seconds, third 30 seconds, until the patient finally quit bleeding, and that's at the point where they stop the timer. So however many seconds that was, that is that patient's bleeding time result. So let's talk normal ranges for that bleeding time test. If they perform that bleeding time test on the underside of the forearm, that method is called the IV method, and the normal range for that test is 2 to 9 minutes for a bleeding time. An alternative to that method is called the Duke method, and it's where they do a small cut on the earlobe versus the forearm. The normal bleeding time for the Duke method, or the cut on the earlobe, is 1 to 3 minutes. And sometimes they use this as an alternative for the forearm because the patient might have some scar tissue, or they may have IVs in both arms and their forearms are not available for the bleeding time test. This test is not usually performed very often, but on a rare occasion you may see a bleeding time test done. So let's think about how our platelet count and our bleeding time can kind of relate to each other. Think back about our platelet lecture and our normal range for our platelets. Our normal range for our platelets is 150,000 to 450,000 per microliter. But if a patient has a normal platelet count, could they have a prolonged bleeding time? Well, yes, they can, because this means their platelets, their numbers may be there. They may have enough in numbers, but their platelets may not be functioning properly. Okay? Something else to consider. Will a patient with a low platelet count also have a prolonged bleeding time? It will be a yes again in that scenario, because the bleeding time test is affected by both the platelet numbers and the platelet function. So let's put everything we've learned in this lecture together for our coag test. In this scenario, we have patient results. We have a PT result of 12 seconds. We have an APTT result of 45 seconds. We have a platelet count of 250 platelets per microliter, and we have a bleeding time done with the IV method, and that bleeding time is 5 minutes. And the question's basically asking you to state the patient's problem. Does the patient have a platelet number problem, a platelet function problem, an extrinsic problem, an intrinsic pathway problem, or is the patient normal? So the very first thing you want to do is you want to go through your patient results and determine if they're normal or abnormal. So the very first thing is, let's look at PT of 12 seconds. That's normal. The APTT of 45, that's abnormal. The platelet count of 250,000, that's normal. And the bleeding time, we're using the IV method of 5 minutes, that is normal. So our abnormal is our APTT. So we know something is affecting this result. Whatever's going on is affecting the APTT result. So make your best guess and try to figure it out on your own before you go to the last slide and see the answer. The answer is the patient has an intrinsic factor problem because the APTT is prolonged at 45 seconds. The APT normal range is only 26 to 37 seconds. I hope you enjoyed this lecture on the common coagulation test, and I will see you over in the next lecture.